Well, hello, everyone. I promised we'd get started at 2:45, and my problem is I can't stop talking and visiting with folks, so I apologize for this. I'm Bev Layton. I'm from Birmingham, Alabama. I'm a nurse. I'm retired from University of Alabama, Birmingham, but I'm still very active with the International Organization of MS Nurses and certainly the consortium. We welcome y'all to Session 3 of Fundamentals of MS Care. Hopefully you've been able to attend some of the others. I think we've got a really good session this afternoon that we're going to be going over. And what I'm going to do, this is a bit of an overview. So this is really looking at multidisciplinary care in multiple sclerosis, and we switched things up a little bit this year. So we're going to start out with Dr. Rinker, who's going to kind of give us that really high-level overview of what the disease-modifying therapies that we have available. Then we have Crystal, who is a nurse. She's also the IOMSN regional liaison. So if you've got nursing questions or about our organization, please reach out to us. Then we'll have a break at 4:15 for about 15 minutes. We'll return with Erica Goff, who's one of our specialty pharmacists there at UAB. And then we're adding dietitian to we're going to have Mona this afternoon, so we've got a nice multidisciplinary team. So I'm going to go ahead and welcome Dr. Rinker up. And Dr. Rinker and I worked together for a number of years at UAB. He did come to UAB in 2007. He spent his fellowship at WashU with Dr. Ann Cross, who helped get him down to UAB for interviews. And when we met him and his lovely family, we knew this was just a great mix. So we're thrilled that Dr. Rinker is joining us this afternoon.
All right, so Bev's used up my first 5 minutes. So that's okay. So I'll try and go quickly. So thank you all for being here. Thank you, Beverly, for the introduction. And I'm going to talk about the approach to disease-modifying therapies in MS. And I've done this particular topic or some variation of it for a number of years now. It's changed quite a bit. When I first started doing it, I approached it more as let's just go through the medications one by one. We'll talk about how they work, pros, cons, all that sort of thing. And it felt very dry, and it was very dry. And then circumstances within the MS pharmaceutical field expanded so dramatically that it became not just a boring way to give a talk, but it also became undoable. There were too many options, there were too many approaches, and so I shifted gears a couple years back and have been trying to approach the topic more from the perspective of when you see a patient, how do you know which treatment to choose? And to do that, you have to know something about the various medications. And so I'm going to work through it in a case-by-case manner. And we're going to start by just talking a little bit about after we get through the first cases, how we actually define efficacy when we talk about disease-modifying therapies. I'm going to talk about how we can organize the myriad of choices we have in MS therapeutics into manageable categories. And then at some length about the various considerations that go into deciding what's the right treatment for the right individual. So I have 3 cases, and I'm going to take an informal show of hands poll because we're going to revisit these cases later in the talk. So we're going to, that way I can see whether I'm having an impact and how you guys are thinking about this topic. So case 1, these are all real-life cases from my own clinic. A 40-year-old woman comes to clinic after an episode of partial transverse myelitis. She was treated with corticosteroids and had a partial recovery of symptoms. She has residual deficits that affect her gait, as well as some urinary urgency that's new. She meets criteria for clinically definite multiple sclerosis based on both imaging, which is typical, and positive spinal fluid results. Her overall MS disease burden is mild in the brain, but she does have multiple spinal cord lesions. which of the following treatments would you recommend? And I know we haven't gone over the treatments yet, but I'm assuming that you have soaked up some of this information in being at this meeting this week. So who votes for interferon beta, choice A? Any hands? None. Natalizumab? Good number of hands. Siponimod, one of our S1P drugs, got at least one there. And ocrelizumab, because everything goes on Ocrevus, right? Okay. All right, I'm going to file that away. Case number 2. 26-year-old black woman developed optic neuritis 16 months before she comes to see you. She tells me at the time that she was treated with steroids and the visual deficit she had with the optic neuritis basically resolved completely. She only has transient visual symptoms now when she gets really hot, like if she's exercising or if it's August in Alabama. 5 months ago, she noticed some weakness and a slight tremor in her left arm, as well as the new onset of constipation. She graduated from the University of Alabama recently and is applying to law school, but she's taking a year off to work and to prepare to take the LSAT. On her exam, she has a left afferent pupillary defect and very slight hyperreflexia on the left side. Which treatment do you recommend? She has a diagnosis of MS. Same 4 choices. Choice A, any hands? Okay. Choice B, natalizumab, couple. Siponimod. Oh man, everybody's going back on Ocrevus again, huh? Okay. And then the last case, 26-year-old woman presents to clinic with 2 years of accumulating neurologic symptoms, blurring vision, double vision, abnormal gait with falls. She's experienced partial recovery after early events, but never to baseline. 6 months after her first symptoms, she lost her job as a Walmart cashier, so she's currently unemployed. Over the last year, she's been going progressively downhill. She has now progressed to the point that she's wheelchair-bound, unable to feed herself due to severe hand tremors, and incontinent. She has both depression and memory loss. We'll start with D and go up. Who votes ocrelizumab? Who votes siponimod? None. Who votes natalizumab? Okay. And then interferon beta. Anybody want to put her on interferon? Okay. I think there were 0 votes for interferon for all 3 of those cases. Okay, so we're going to move away from those, but we're going to revisit them. And as I move into talking about the treatments themselves, I did want to take this opportunity to just put the vocabulary out there. Some of you may have been exposed to this, but at least historically, there was a lot of loose use of terms around MS disease activity. And so I try and stay as consistent as I can when I talk about how MS is behaving and whether or not somebody is having a response to treatment or not. So for purposes of this talk, a relapse is a clinically symptomatic inflammatory event. So an MRI lesion is not a relapse. A clinically symptomatic demyelinating event is a relapse. Disease activity could be a relapse, or it could also be a new MRI lesion or an enhancing MRI lesion. Progression is related to disability, but specifically describes the insidious worsening of MS that can be due to a combination of both neurodegeneration as well as inflammation. It's important that progression is not linked to failure to recover from a relapse. Those are separate issues. Disability, as we use it in the MS world, is neurological impairment, and this can result from either incomplete recovery from a relapse or from progression, that insidious worsening. And disease worsening can mean increasing disability either due to an incomplete recovery from a relapse or to progression. So when I say someone's progressing, I'm specifically referring to that gradual worsening. And when I say worsening, I mean they're accumulating disability, but I'm not being specific about how it's happening. Okay. So it's easier to visualize some of these outcomes, I think, graphically. So if you look at this chart here, this is one of my favorite graphs that I pulled from the literature many years ago. It nicely represents on the top the, let's see, do I have a cursor? best way to? Oh, well, I'll just be descriptive. Oh, it is working. Oh, there it is. Okay. It's hard to see. So on the top here, this is clinical disease activity, and on the bottom, this represents both clinical and radiologic disease activity. And so on the top, you can see disability is represented by an increase in those green bars away from the baseline, which would be lack of disability, no disability. A relapse are these vertical bars that represent acute worsening of neurologic symptoms with either complete recovery or incomplete recovery over time, which would then indicate worsening in this failure to recover to baseline. Disease activity, on the other hand, is any sort of evidence of inflammatory demyelination. If it crosses the threshold here, which is this dotted line, then you have a relapse, and if it fails to cross that threshold, you may just have a new or an enhancing MRI lesion. And then secondary progression on the upper right here is this more insidious worsening that occurs following a period of relapses. So these next two slides demonstrate why I no longer go through these medications item by item. And you'll also notice that I have not included the generic names in this particular timeline, simply because for the most of the history of MS therapeutics, we largely thought of these drugs by their branded names. And since we now have generic versions of many of these, I thought it was more helpful to include the branded names as well as the generics once they became available that way. So you can see, beginning in 1993, with the first therapeutic, we had beta-seron, and then really until about 2010, the field did not change very much. We had Tysabri, which is the first infused medication, come along in 2004, and then with Gilenya or fingolimod, that was the first of the oral medications, and it was really at that point that the floodgates were unleashed, and we began seeing frequent new medications coming out almost on a yearly basis. So my timeline has gotten so long, I had to extend it into a second slide. And we're currently, I haven't included the generic natalizumab yet. I did include it on there. But there's certainly more to come. All you have to do is attend some sessions here to learn about some of the newer treatments that are coming along. And I did not include any of the more advanced experimental things like cell-based therapies like we heard about from Dr. Cohen this morning. So how do you approach that many medications and treatment options? Well, my daughter's into math, and so I thought I'd have a math slide on this. So there are currently 27, or there have been 27 approved and marketed products for multiple sclerosis. 3 of those have multiple dosing options, so I added 3. I subtracted out Navantro and mitoxantrone. It's still FDA approved. You can still use it, but I don't know of anybody who does or has for many long years now. Mainly because of its significant toxicity. It can cause heart failure even in a delayed manner. It can cause secondary malignancy, and it can cause amenorrhea and infertility problems as well. So we just really don't have many justifications for using it. Daclizumab was also released and then withdrawn from the market due to hepatotoxicity. And that leaves 28 therapeutic options for MS in 2024. So how do you begin a discussion with a patient who's newly diagnosed on which medication to go on? Am I going to go through 28 separate options? I am not. So you have to sort these medications in some kind of way. And kind of like a bathtub full of mixed currency, you can do it by all different ways. You can do it by country of origin, what the metal's made out of, how big it is there a hole in the middle of it, all kinds of different ways. And so I listed some of the categories that you can group these medications in on the sides, and I'm going to go through of some of these in detail. But you'll notice the first one I list at the upper left-hand corner is efficacy. And so before talking about any sort of treatment discussion with the patient, the first question I'm asking myself is, what kind of efficacy do I need to be thinking about with this particular individual? And fortunately, most of these drugs, or many of these drugs, are similar in that there's some common mechanisms of action that allow for easy grouping of them together. And despite the early warring between some of the interferon manufacturers about which one was superior to the other one, the bottom line is that they're really not all that different from one another. So if you whittle those 28 treatment options down, you come down to about 9 distinct mechanisms of action, which is a much more manageable number to talk about. And if you put them on a sort of spectrum of efficacy, this is not a scientific lineup here, they're just sort of crudely grouped together. You can see on the left-hand side, you have the not low efficacy, but lower efficacy medications like the glutaminyl acetate, the beta interferons, a couple of the oral medications, the fumarates and teriflunomide. The S1P modulators kind of fall somewhere in the middle. And then you have your higher efficacy medications on the right with the B-cell depleting agents, natalizumab, and then the induction therapies, cladribine and alemtuzumab. And I'll have some evidence on some of these specific mechanisms of action that illustrate their relative efficacy to one another. So going back to our case, how do you recognize a patient in need of high efficacy therapy? And there is no crystal ball, there's no perfect algorithm that allows you to identify who absolutely would benefit or requires the highest efficacy versus medium efficacy versus lower efficacy therapy. But there are some general principles that if you think about them in a consistent way as you see patients, will allow you to make an educated judgment or at least an educated panel of recommendations that you'll then sort of filter further as you talk about other factors that might be relevant to that individual. So on the favorable prognosis side, we have patients with a younger age, patients who have sensory symptoms rather than motor symptoms at onset, complete recovery from their initial symptoms, a unifocal attack versus a multifocal initial demyelinating event, relapses that are widely separated in time, a low overall disease burden, the absence of spinal involvement, and some certain demographic characteristics. Females tend to do a little bit better than men, and ethnically whites tend to do a little bit better than African Americans. The more worrisome characteristics tend to be older age, motor deficits, incomplete recovery, multifocal onsets, high frequency relapses, that is, relapses occurring close together in time, lots of lesions on their MRI scans, spinal involvement, and then the demographics we already talked about. So here's our case again. And if this is the first case, so this is the woman with transverse myelitis, partial recovery with some residual deficits in the spinal cord. So if we look at our favorable versus unfavorable prognostic markers, we can recognize that she has a lower disease burden. That would sort of work in her favor. But she is 40 years old, which puts her a little bit on the older side for an initial diagnosis. We learned that she had motor symptoms at onset, that she did not completely recover from that initial episode, and she has clear spinal involvement. So just extracting those details from her history, you can begin to see that this is a patient where, with inadequate efficacy of therapy, this person is likely, not guaranteed, but is more likely to accumulate additional disability if we don't treat her aggressively enough. Which means we're going to be looking towards the right end of our spectrum of efficacy. So that brings us to question number 2. If these are the choices, we're kind of looking at the S1P medications, B-cell depleting drugs, or natalizumab, not really talking about induction therapy here, but looking on the higher efficacy end of things, how then can we further narrow this topic down for her and help her be comfortable with the treatment that you might recommend? So on the one hand, you think about safety. On the other hand, you think about side effects. So I consider these topics as sort of similar, but also separate. Safety particularly comes into question when you're talking about the higher efficacy medications. If you're talking about changing a person's immune function in such a substantial way that you're going to prevent MS disease activity, chances are you're also going to introduce additional risks that may not otherwise have been there. The side effects are really more medication specific, and as it happens, a lot of the higher efficacy drugs don't actually have a lot of side effects associated with their administration, partly because a lot of them are dosed infrequently. But especially for patients who are considering a lower efficacy therapy, sometimes the side effect profile can be quite important. So let's now dig in a little bit to the individual kind of groups of medications, and I've lumped them largely together by mechanism of action. Not exclusively, but mostly. So if we go all the way back to the beginning of the MS therapeutic era, so the early 1990s, we first had interferon beta 1b, and then later two interferon beta 1a formulations that were made available, as well as glatiramer acetate, which was another injectable medication. All of these initial MS drugs were given by self-administered injection. And you'll notice that there's slight differences in the frequencies, and sometimes that was the important deciding factor, a weekly injection as opposed to an every other day shot, or even a daily injection with the early glatiramer acetate, were some of the considerations that we made. As it happens, the beta interferon mechanism of action is still probably the most complex of all of them. I put this graphic up not to explain it, but just to illustrate through its overwhelming busyness that I'm not going to be able to completely explain how beta interferon works. I think to this day there's still some debate about which of its many properties actually is effectual in multiple sclerosis. I think looking back, a lot of its benefit may have to do with its ability to prevent lymphocyte movement in and out of the central nervous system, but there are other factors as well. Glatiramer acetate, on the other hand, has an interesting backstory, and that this was a drug that was initially developed in Israel by scientists who were attempting to induce EAE, which is an experimental model of multiple sclerosis in animals, but they inadvertently found that this particular combination of amino acids, which were highly prevalent in myelin basic protein, actually prevented development of EAE. And so this ultimately turned into a treatment that was effective in humans, meaning it started in the animal model and then became effective in clinical trials. And it's thought to work by inducing anergy in the autoreactive T cells that cause damage in multiple sclerosis. So to this day, it's one of the more antigen-specific therapies that we have for multiple sclerosis, but it still falls in that sort of more modest category of efficacy. If you look at these old platform therapies side by side together, I'm not going to walk you through this entire table, but I do want to sort of draw your attention to the reduction in the annualized relapse rate. These are clinical relapses, not MRI disease activity. You can see that the reduction across groups for each of these medications was very similar. And because of this similarity between the medications, despite them being interferon or glatiramer or dosed every other day versus once a week, there wasn't a whole lot of difference. And so I think to this day, those of us who still use these medications sometimes think of them sort of collectively as a single unit, or at least as a therapeutic option. One of the major problems about the old platform therapies, one was the fact that they had to be injected. And so patients who had difficulty with that, or were needle averse, or who had bad injection site reactions often found taking these medications problematic. In addition, with the beta interferons, they also tended to have some of the worst side effects of the various medications that are available for MS. Flu-like side effects being the most common, but they can also cause hematologic abnormalities, liver function test abnormalities, depression, miscarriage, especially early in pregnancy, and then, of course, the injection site problems. Glutaramine acetate was much less problematic, but it required more shots, and so there were more injection problems there. Over time, some of these medications were sort of birthed generic versions of themselves, or there was a pegylated version of interferon that was released that allowed for injection every 2 weeks as opposed to once a week. So there have been some next generation platform therapies, but they're generally viewed as basically the same as the original platform therapy. So I sort of lump them all together. Moving on to the oral therapies, fingolimod was the first one to be FDA approved in 2010. It's considered an S1P receptor modulator. And the therapeutic effect of these medications in multiple sclerosis is thought to arise from its ability to prevent lymphocytes, that is, the adaptive immune cells, from moving out of the peripheral lymph tissue, specifically the lymph nodes, such that if you do a blood test on somebody who's taking one of these medications, their measured lymphocyte counts will be very, very low, sometimes as low as you might see in someone who has HIV or AIDS who's not, on therapy. So they have a significant benefit in reducing lymphocyte trafficking throughout the body, which indirectly limits lymphocyte movement into the brain or the spinal cord. Unfortunately, these S1P receptors are found throughout the body on other tissues, and so one of the, I would say, relative barriers to using these medications in patients was the systemic side effects or safety considerations that went along with this category of medication. So macular edema can result, which can cause blindness if not addressed early on. Lymphopenia, like I mentioned, leads to opportunistic infection risk. Zoster outbreaks are increased in patients who take these medications. And there were some early concerns as well about even skin cancers, and there have been some rare cases of PML. The next oral medication that was approved was teriflunomide. This one works by reducing activated B and T cell development by blocking the pyrimidine synthesis pathway. Teriflunomide does require close liver monitoring in the first 6 months to ensure appropriate metabolism of the medication. Once that occurs, if you get through the first 6 months without significant liver enzyme elevation, the metabolism becomes less of a concern. But for some people, it can cause bothersome side effects like hair loss, and it's notably teratogenetic. So if you're talking about treating young females with childbearing potential, you are likely going to look elsewhere before you consider teriflunomide as a therapeutic option. The third of the oral medications to come along was dimethyl fumarate, and this medication reduces lymphocytes to a modest degree. It also activates something called the NRF2 pathway, which is thought to be neuroprotective. And one of the notable differences between this medication and the other oral drugs is that it required twice daily dosing. It also had some of the more bothersome side effects of the oral medications, not so much safety, but side effects, in that it causes frequent flushing, where people will turn very bright red in the face or on their chest. It can act like a sort of a random hot flash that just occurs out of nowhere. And some people can find this sort of embarrassing or cosmetically bothersome. It can also cause GI upset in some individuals to the point of even discontinuation. And it can also cause lymphopenia, which if you have significant lymphopenia, puts you at risk of opportunistic infections like PML, which has been rarely reported. So how do we know how these drugs compare to the old platform therapies? Well, at the time that the clinical trials for these medications were being conducted, it became common practice to include an active comparator arm in the clinical trials. And so we know a little bit about the relative efficacy of some of these medications. The fingolimod trials did demonstrate superiority to low-dose weekly interferon beta-1a, while the dimethyl fumarate and the teriflunomide trials were unable to show, they were efficacious, but they were unable to show superiority to these platform therapies, glutaminyl acetate and interferon beta. Moving now into the high-efficacy therapies, natalizumab was actually initially released in 2004, withdrawn from the market, and then re-released in 2005, was the first of our high-efficacy medications. And it works also, like I've mentioned before with some of the other medicines, through interfering with lymphocyte trafficking. So that's sort of a common denominator with a lot of these effective therapies. Natalizumab blocks something called alpha-4 integrin, which is found on circulating lymphocytes and prevents their movement across the blood-brain barrier into the brain or spinal cord. Compared to the platform therapies, the reduction in relapses was about twice as effective, which was really a game changer when it first came out. And I think initially a lot of MS practitioners were ready to put large portions of their patients on this medication, except right as that was occurring, it came out that there were 3 cases of PML, or progressive multifocal leukoencephalopathy, that developed in patients who were taking this medication, some for multiple sclerosis, and then there was a parallel trial for Crohn's disease. It wasn't initially known whether it was this drug combined with some other agents that were also being given with those trials, but over time it's turned out that it's really a specific effect of natalizumab, and particularly in patients who have active JC virus replication in their body. JC virus is the virus which causes PML, and you can detect viral activity indirectly by measuring antibodies directed against the virus in the serum. So to this day, we have stratification measures to look for JC virus activity with a blood test, and we also monitor how long we treat patients with this medication. More than 2 years of treatment with positive JC virus antibodies markedly elevates a person's risk for PML. On the plus side, natalizumab had a strikingly strong effect on reducing not just relapse rates, but also disability. This graph on the right here depicts the difference in the placebo group versus the natalizumab group in the pivotal trial, and it shows a wide separation over the course of 2 years in patients who were receiving natalizumab. The other infused high-efficacy immune suppressants, or the other infused high-efficacy medications are immune suppressants. Ocrelizumab targets CD20 positive cells, or B cells, and is administered every 6 months. Over time, it does increase susceptibility to certain infections, particularly upper respiratory infections caused by viruses. And it can cause long-term hypogammaglobulinemia, the consequences of which we really don't know, what happens to somebody when they've been B-cell depleted for, 10, 20, 30 years. So there's an ongoing debate. I think there's even a parallel session right now talking about extended interval dosing of these kinds of treatments. Infusion reactions are quite common with ocrelizumab, but for most patients, as long as they have an experienced and reassuring infusion nurse on hand, those infusion reactions can be easily managed. Alemtuzumab is a more aggressive immune suppressant medication that's also a monoclonal antibody that depletes not just B cells, but also T cells by interacting with the CD52 cell surface antigen. It's administered, it has a lifetime maximum dosage. It's typically given over 2 years, over five treatments, 5 days in a row in year 1, and then 3 sequential days 1 year later. Patients who take this medication have to have monthly lab work for 5 years once they receive the last dosage. And because of the severe immune suppression that occurs, you have to worry about not just opportunistic infections, but also secondary autoimmune conditions, which can result as the B cells and the T cells repopulate in an uneven pace. And so as these immune cell populations reconstitute, they can sometimes trigger additional autoimmune problems that were not there prior to treatment. We don't have the side-by-side comparisons of these drugs with each other, but just relatively speaking, looking at some observational studies, it seems clear that the teriflunomide and dimethylfumarate are more modestly effective. The S1P medication, fingolimod, is more intermediately effective, and natalizumab, ocrelizumab, and alemtuzumab tend to be in the highest efficacy category. I've also included effects on reducing disability, which, as you might expect, is more pronounced in the high efficacy drugs. The dosing is different, oral versus IV, but the interval it varies. And so sometimes when transportation is a challenge or mobility is a challenge, how often the medication is given can be an important consideration. Side effects, like I said, you can have some with some of the oral medications. The infused medicines don't tend to have a lot of side effects other than during the infusions themselves, but they do have increased monitoring requirements, like for the JC virus antibody activity and for the monthly lab work with the alemtuzumab. Finally, there's another induction type therapy that's more of a global immune suppressant called cladribine. This drug came out, was actually in trials at the same time as some of the other high efficacy medications, but it was only more recently approved by the FDA. It's given as an oral chemotherapy agent over 2 years. You have 5-day cycles, 4 weeks apart, that's then repeated a year later as long as a patient has had sufficient rebound of their lymphocyte counts. Not everybody has that rebound, and even if you get the rebound after the first year, it's not uncommon for patients who take cladribine to have lifelong immune suppression after they finish the course of treatment. It's approved for breakthrough disease in both relapsing and active secondary progressive multiple sclerosis, and it may carry some secondary malignancy risks, and like I said, long-term bone marrow suppression. Now we get really into the weeds. I mentioned earlier that the S1P receptor medication, fingolimod, one of its limitations was that the S1P receptors were located on multiple other tissues throughout the body. And so in more recent years, efforts were made to develop selective S1P receptor modulators, and that led to the development of siponimod, ozanimod, and ponesimod. And one of the important benefits of these selective medications is that they're easier to get started. With fingolimod, patients had to come into clinic and spend 3 or 4 hours being observed after they took the first dose of medication out of concern for symptomatic bradycardia. Now with the newer medications, patients can take them at home on a titration schedule and don't have to come in for that long first dose monitoring. We still generally recommend that patients see the eye doctor every year, and we still recommend dermatologic assessments as well. There are some considerations with metabolism in these medications. Patients going on siponimod get a genotype done that helps determine what their expected hepatic metabolism of the drug may be, and that determines the actual dose that we end up giving patients. Some of the other medications like ozanimod may also have interactions with certain other categories of medicine like SSRIs, although that's not really played out to be a significant problem in clinical practice. The fumarates have also spawned their own progeny. Not only is there now a generic version of dimethylfumarate, there's another medication called diroximel fumarate or Vumerity that was developed specifically with the purpose of trying to improve the GI tolerability of the medication. And then there's monomethyl fumarate, which is actually the active drug that the other drugs become. The others are prodrugs that become monomethyl fumarate once ingested. We really haven't used this one, I think, largely because the lack of insurance coverage for it. But it is out there as a potential option. And we also have now 2 additional forms of B-cell depleting drugs like ocrelizumab. Ofatumumab is a self-administered injection that's given once a month by patients at home. There is a titration in the first month, but beyond that, it's a simple once-a-month auto-inject type delivery treatment that patients who've started on it generally find very convenient. The effects seem to be very similar clinically, although we don't have any head-to-head trials comparing this approach to other infused B-cell depletion. Ublituximab is the newest B-cell depleting medication. It works very similar to the ocrelizumab, except that you're able to give it over a much shorter time period after the initial infusion, which we'll see how much of a benefit that has in the long term. I think it's largely going to come down to insurance coverage, whether people are able to access this or not. So that's a lot of information, and we're going to try and apply some of this now to our initial case. In talking to our patient, the one we're trying to treat, we talked about efficacy considerations, but now we've talked about safety and side effects, but we also need to consider some of the specifics of the drugs themselves, how they're delivered, oral versus IV versus injection, and a lot of whether or not something's appropriate for a patient is going to come down to whether that individual is willing to take a shot at home, or if they believe themselves to be reliable pill takers. The frequency is important, especially depending on what kind of maybe job somebody works. If they're a truck driver and they're driving nights, a twice-a-day pill with an uneven diet and an irregular sleep schedule may not be an ideal treatment. The time requirements for dosing, all of the startup requirements that are required. We recommend vaccines before the B-cell depleting drugs and the other immune suppressants. And so getting people, on adequately vaccinated for things before they start treatment can sometimes be a barrier. The monitoring requirements are an important consideration, especially if patients are not reliable at coming to follow-ups or have difficulty going somewhere to have blood drawn. Side effects are a concern, as are safety, like I mentioned. And then there's the long-term effects that we may not even fully appreciate yet. And cost, which is the big insurance barrier for a lot of patients. You also have to think about characteristics of the patients themselves. What kind of MS do they have? Are they early, straightforward, relapsing, remitting, or are they maybe more in an active secondary progressive phase? What's the risk tolerance of the patient? Some patients remain very wary of anything that you describe as an immune suppressant or that may put them at risk to their health. When you say the cancer word, the C word, that often puts a lot of people on the defensive, even if the likelihood of that is very minimal. You have to make your own judgments about how likely a patient's going to be compliant with a certain medication, and you have to sometimes consider comorbidities. With the S1P medications, there may be increased rates of things like macular edema or cardiac comorbidities in patients who already have those conditions. So you may choose not to use a medication like that in a person with a lot of other health problems. Social limitations, which is certainly a consideration where I live. There's lots of poor rural patients who live in poor rural areas where accessing medical care is not easy. Family planning is an important thought to consider, especially in a young female patient. And then the impact of these medications on home and work. Do you want to put somebody on an immune suppressant if they work in an elementary school? That's not an absolute contraindication, but it is something to think about. And then you have to consider the financial impact of any of these medications on an individual, not just the direct cost, but also the indirect costs of going back and forth to clinic, taking time away from work, and that sort of thing. All right, so patient 1. We did some lab work. She's JC virus antibody negative. She has good immunity against varicella, which is important for starting on a B-cell therapy or an S1P medication. But she's averse to immunization, particularly the COVID vaccine, also a very Alabama problem. She has missed 2 follow-up appointments, which were scheduled to discuss her treatment options. She's also been prescribed some antihypertensives, but her blood pressure's, quite elevated in clinic. Now, it could just be the circumstances of why she's there, or it could be that maybe she's not entirely compliant with taking medications at home. She also lives 3 hours away, and she's a single mother with 2 teenage children at home that she's caring for. So what would you choose? Well, we've already decided we're not going to go low efficacy here. 1, because she has aggressive disease, and 2, because of the what's required to take medication or injections on such a frequent basis, and based on her history. So we're not really talking about induction therapies here. So once you kind of eliminate the obvious poor candidates, we're really just left with a couple options. Natalizumab, in her case, she's JC virus antibody negative, or a B-cell depleting agent. So I think that was where the hands were at the beginning of the talk. So I think we're probably on the same page. I can't really remember if she ended up going on the B-cell depleting drug or the natalizumab, but it was one of the 2. Let's see if the votes changed at all with this next case. This is the 26-year-old woman. So she had optic neuritis with a good recovery. She's not had any more major relapses. She had maybe some subjective weakness and a tremor, but those were not really appreciated when you saw her in clinic. So she's young, she's female, she had a sensory initial episode, and she's not had frequent relapses. So other than her ethnicity, she's really a pretty low-risk category. Who would now vote for interferon? Anybody who would recommend that now? What about natalizumab, assuming she's negative? Okay. Siponimod? Okay. All right. Ocrelizumab? Everybody still wants to put her on Ocrevus. Okay. So she's actually coming back in the next week or so to make a decision. I'm going to tell her she can go on whatever she wants to go on, but certainly something like siponimod would be, I think, a reasonable choice for her, given that her disease activity is relatively low, and she's a reliable individual. Yes, she's a little bit higher risk, maybe being African American, but beyond that, all of the other indicators would put her in a lower risk category. And if she was wary of anything about that, and she wanted to go on an old injectable drug, I wouldn't stop her. What about the third case? This is the woman who clearly has a very aggressive, active, debilitating disease course. No one raised their hands for interferon, and I'm guessing that's still the case. Who would vote Tysabri, natalizumab with her? Ocrelizumab? Okay. So this patient actually came to see me early on before ocrelizumab was even an option. She went on natalizumab. She was JC virus negative, and she actually was the beneficiary of an effect that I've seen sometimes with natalizumab, and that is not only did she stop having relapses and stop getting worse, but she actually regained quite a bit of function. So she regained the ability to walk. She now walks independently with no support required. It's not always pretty, but she can do it. She has regained continence. So a lot of the more severely disabling characteristics she had, she got back while she was taking natalizumab. And I haven't really seen that regression of disability even with some of the other high efficacy therapies like I have with natalizumab. And so sometimes when I see people going downhill fast, I think about natalizumab as a good choice, particularly if they're JC virus negative, and even sometimes if they're positive, as long as it's going to be a limited duration of treatment. So, future directions. These are things that we don't really know the answers to yet, but some of these questions are being actively investigated. Like, does the benefit of early aggressive therapy outweigh the risk? There's some trials ongoing right now to assess the benefit of early aggressive therapy. And, can we determine, the future disease course well enough to decide which patients are going to be the biggest beneficiaries of aggressive treatment and which not? And then if we do use an induction approach, should we or can we then pursue a maintenance approach where we use maybe a lower efficacy therapy once they've completed the induction, particularly if there's additional disease activity? So I will stop there. I think I'm just a few minutes over. Okay, does anybody have a question? Yes? Dual therapy? So historically, yes. Actually, the natalizumab trial included a combination therapy arm with interferon beta 1A. That was when the PML cases turned up, and so initially there was some concern that maybe it was the combination that was making PML happen. That turned out to probably not be the case. And then around that same time, there was a huge NIH-funded study called CombiRx that looked at combining the old platform therapies, glatiramer acetate and interferon beta. And ultimately, that combination therapy using two lower efficacy medications did not find that the combination was better than either a single drug by itself. And so while in the future there may be room for talking about combination therapies, those, I think, two experiences have sort of solidified in most neurologists' minds that MS, at least for the time being, is going to be a single agent treatment. Plus, the cost of combining these expensive medications, I think, would be prohibitive for most people. So, yes?
Okay, I ask a question. Mm-hmm. So for SPMS, active SPMS, for S1P, the one that has data is the siponimod. Would you use the other S1Ps to treat the active SPMS?
That's a good question. I really think that a lot of the sort of niche indications for some of these medications comes down more to trial design and how some of the clinical trials were designed. I think of the drugs as really fundamentally being more similar than different. And so while I may choose one because it has that specific indication, like it may be easier to get siponimod for a patient who fits that description than one of the other S1P medications, I don't really believe in my heart of hearts that it's actually better than the others. I think, if push came to shove, I would just use any of them and presume that the effects are going to be similar enough that it won't matter. Okay. All right. Thank you very much.
And I think Dr. Rinker will be here through the time of the break. So let me go ahead and welcome Crystal Wright coming up. And Crystal is a nurse practitioner at UT Southwestern. I'm going to let her tell a little bit about herself. Come on up.
Thank you, Beverly. Like she said, I'm a nurse practitioner at UT Southwestern in Dallas, and my talk today is called Behind the Scenes of Therapy and Changing Disease Course. And with full transparency, I inherited this talk from a mentor of mine who was going to be speaking. And I think she had a vision of having a talk to kind of bring everything back together and summarize some things, but also look at some of these specific cases that we don't have clear guidelines for and talk through some of that. And so I don't know if I'm doing her justice with this talk, but I really liked her vision, and so she is to credit for that. So we'll kind of dive in here. Lots of things to discuss. So I want to start by kind of talking about where we've come in the last 2 decades, because I think that some of the areas that are going to be discussed today, the reason why we're even discussing them is because of the strides that we've made over the last 20 years or even 30 years. So in the last 2 decades, we've seen improvement in the diagnostic criteria. The 2017 criteria included CIS. We've seen huge advancements in MRI technology and what we can see on MRI. There's been blood-based proteins added to the labs that we can do to look for inflammatory process. There's neurofilament testing that can be done looking at the inflammation. And then we've seen great advancements in our disease-modifying therapies, as you just saw with the last talk there. There's been improvement in genome mapping technology, but I think one of the biggest things that we've seen is a better understanding of the basic immune drivers behind MS and understanding that there is more involved than we originally thought. So previously, MS was thought to really be driven by T cells, and now it's recognized that the B cells are also a key driver in the tissue damage, and that B and T cells both drive the inflammation that we see. And then there's this new understanding that there are immune cells that are trapped in the central nervous system that lead to this degeneration or progression over time. Because of the advancements that we've seen, we now can have give people a diagnosis earlier, get them started on medication earlier, and MS is now a manageable condition. I started in MS about 16 years ago, and at the time, I was the person in our clinic that would sit down and talk to individuals about which therapy they wanted to go on. And we had the ABC drugs, Rebif and Tysabri, and I remember talking to them about the medication is not 100%. The goal is to reduce and slow progression. And at that time, that's what we had. And looking at the medications that we have now, and to think that there are patients out there that we're able to get a very good, tight control on their disease is huge. So with these advancements, we've seen better quality of life, less disability, less chronic symptoms in these individuals. So despite these advancements, though, we still lack great options for those with progressive disease, both secondary and primary progressive. So one of the questions we have is, can future medications target some of this progression, targeting the activated microglia, and then where will BTK inhibitors fall, and will they show evidence that they can prevent this inflammation and degeneration? So this is a similar slide to what Dr. Rinker showed earlier, and I like this one because it kind of shows MS across the lifespan there. And for this specific talk, we're going to focus on the preclinical phase and then the progressive phase at the end. This illustration here, the black arrows at the bottom, are the inflammatory processes, the changes on MRI. The brown line going up is the disease burden, the green line is the disability, and then the red line that is coming down is the brain volume that changes over time. So for the preclinical phase, we're going to focus on RIS and CIS. And RIS is this area right here where there has not been a clinical attack yet. Not a clinical attack and no clinical disability, but there have been MRI lesions. And then the CIS is going to be right here where that first clinical event occurs. In someone, though, that has these other inflammatory processes, they would not necessarily meet CIS would have been clinical definite MS at that time. So we'll talk more about that. So radiologically isolated syndrome, I know if you attended the earlier fundamentals talk, this has already been discussed quickly, so we're going to just kind of review that as well. So it was defined in 2009 as the presence of asymptomatic, incidentally identified demyelinating appearing white matter lesions in the central nervous system. So basically these individuals have MRIs for something outside of MS. They're not having clinical symptoms. Maybe it's a car accident, a head injury, headache, something like that. And their MRI is typical of someone that has multiple sclerosis. They have lesions that look like MS based on location and shape and size, but they have not had a clinical event. So there was a 2014 publication by Dr. Akuta, which is one of my colleagues, that looked at these individuals that are diagnosed with RIS, what happens over time. And the study found that at a 5-year follow-up, 34% of the patients did go on to develop clinically definite MS. And of those, 10% actually went on to develop primary progressive MS. The predictors for developing MS, the higher risk factors, were age, greater than 37, male sex, and then the presence of spinal cord involvement. There's also presence of dissemination in time. So individuals who, they have the initial MRI, you're following them because you're suspicious that they may go on to develop MS. Having another event on that MRI, meeting dissemination in time is also predictive. So clinically isolated syndrome is also one of these preclinical syndromes. Not preclinical, it's the first clinical syndrome, I should say. And it is a single episode of central nervous system dysfunction. It can be a unilateral optic neuritis, a focal brain syndrome, or a focal brainstem or cerebellar syndrome, or a partial myelopathy. In these individuals, the presence of having oligoclonal bands is the biggest indicator that they may go on to develop a second attack. And in the 2017 criteria, it actually, you can use those presence of oligoclonal bands in place of dissemination in time for the diagnosis. So the question that we have now that we can recognize RIS and CIS is, do we treat these patients? So there is a trial, the ARISE trial, which is was a 12-center randomized controlled trial looking at dimethyl fumarate compared to placebo with a 96-week time frame. Does it reduce the risk of developing clinically definite MS? And dimethyl fumarate did reduce the risk of developing clinically definite MS by 82%. So with that trial, I do think we should consider treating patients with RIS if they have risk factors, the spinal cord involvement, presence of oligoclonal bands, or they've met dissemination in time. And then CIS has been around a little bit longer than RIS, and there are more trials for CIS. I'm not going to go into great detail on these, but just so that you have them, they're listed here. All of these trials show that there was a benefit of starting medication early in these CIS patients. And even the follow-up trials looking at 3- and 5-year data, the individuals treated with either interferon or glatiramer acetate, they had a benefit long-term. They continued to show benefit in reduction of clinically definite MS, even at 3 and 5 years. So there are now several DMTs that are approved for clinically isolated syndrome, and those are listed here. All right, so we're going to do a case study. This is an individual from our clinic. It is not my patient, but it was someone that was given to me to use for this lecture here. So Sam is a 22-year-old black male college student who was referred to our clinic for abnormal MRI of the brain. He had a concussion, so they did an MRI, and on the MRI, they found that he had extensive, nearly confluent supratentorial white matter lesions with multifocal involvement of the corpus callosum and infratentorial upper cervical cord lesions. So because of the, and there was a 3 millimeter enhancing lesion as well on the MRI of the brain. Because of the findings of the MRI of the brain, a MRI of the spine, CNT spine were also done. On those MRIs, they did find that he had additional lesions in both areas, and this gentleman did not have any symptoms. He denied any sensory or motor symptoms, no cognitive symptoms, no vision difficulties. He was a healthy individual, nothing going on there. So an LP was done that was consistent with MS as well, with 12 oligoclonal bands in the CSF and only 3 in the serum, and it also had elevated albumin, IgG index, in an IgG index. So what would you do with this individual? Would you treat him? Would you not? So that brings me to the question here. So A would be, since the patient has not had any symptoms, you'll watch them and see what happens, maybe re-imaging in 6 months. B, recommend starting an oral treatment such as dimethyl fumarate, given the ARISE trial results. C, recommend a more aggressive treatment option for the patient, such as ocrelizumab. Or D, tell the patient he is unlikely to develop MS. So we're going to do a show of hands again because I think that worked well. Who would go with A? Okay. What about B? Who would do C? And who would do D? Okay. So we don't have clear guidelines yet. And so I think this is one of those reasons why we need to discuss and talk about these topics. I think any of these answers except D could be appropriate. Would it be off-label? Absolutely. But could it be appropriate? Yes. Dr. Rinker talked about risk factors in individuals with MS, and this gentleman had many of those. He had extensive disease involvement of his spinal cord. He was African American. So I do think that that would be a reasonable option to do any of these 3. I probably would not have done A, but without guidelines, I could see where somebody would be fine with that. So this gentleman was actually part of the ARISE trial, so he was started on dimethyl fumarate twice a day. And 6-month follow-up, he came back and he had intermittent numbness and tingling in the right arm. So a new MRI was done of the brain and the spine. There were 2 new lesions on the MRI of the brain, and the spine remained stable. So which option now do you think is most appropriate for Sam? Would you continue on the dimethyl fumarate that he's been on, or would you switch to a high-efficacy treatment such as ocrelizumab? Who would do A? Who would do B? Man, you guys are good. All right, so markers of aggressive disease. So this is kind of building on what was already discussed in the prior talk. You know, you can look at a patient's initial profile and determine if they're going to be an individual that may have more aggressive disease based on their ethnicity, presentation, and many other factors too. But in 2018, ECTRIMS met. There was a meeting at ECTRIMS to discuss what are the markers for more aggressive disease. And these are the criteria that they came up with. So individuals who have a rapid progression of disability over time, severe relapse leading to an EDSS score increase of greater than 1 or 2 on any functional system, and relapses requiring steroid therapy or hospitalization. I do think you have to be careful with that one. Sometimes people are seen in the hospital and the provider they see are not familiar with MS, but they know that you give steroids for MS. So a lot of times they go in for a UTI and they come out with a course of steroids. And so, pseudo relapses are not a predictor of aggressive disease. So just be mindful of that. Anyone who has multifocal attacks or incomplete remission, or attacks affecting motor, cognitive, sphincter, or cerebellar systems. Or individuals who have frequent relapses in the first year, or individuals with short intervals between their relapses. And then those who have an early accrual of disability. So one of the questions we get asked frequently when we diagnose MS is, I've been reading online, there's multiple types of MS, what kind do I have? So am I relapsing or am I primary progressive? And this has been covered in probably 20 talks this week, so it's going to be just a quick review of that. So relapsing remitting, those are individuals with acute attacks or new lesions on MRI. They can have enhancing lesions, typically diagnosed earlier in life, less than 40, and 3 times more common in women. Where primary progressive, you have to know more about the patient. You need to know what they've looked like over the last 12 months. And if you're just meeting the patient and you don't have a clear history, you might not be able to tell them right away that you think they have primary progressive. So you need a 12-month history of progression. You may have more spinal cord lesions in these individuals. There may be a gradual worsening with accumulation of disability over time, typically diagnosed later in life in these individuals, and occurs in men and women equally. Primary progressive can have active lesions, or it can be non-active. And then secondary progressive, and we're bringing this up because we're going to move into some ideas here with with secondary progressive disease, is a after effect of relapsing remitting. So when an individual has relapsing remitting for a while and they have lost enough cognitive reserve, or they've had enough neurodegeneration over time, they start developing these progressive symptoms. And that is what secondary progressive is, a gradual worsening of relapses, of the relapsing course of the disease. Individuals with secondary progression can still have relapses, and that would be the quote-unquote active secondary progressive MS. And then it's important to remember that progression is not always linear. They can have plateaus, they may have a little improvement, it may change over time. I really feel like the neurocognitive reserve can fluctuate day to day based on sleep and levels of fatigue and exercise. All of those things I think do play a role on some of the symptoms as well. And so individuals going through a rough time in their life may have more progression and then kind of level off for a little while. This is the 2017 McDonald criteria for diagnosing MS. We are not going to go into detail on this. I'm giving it to you here because we're about to have a new criteria that's going to be coming, and so we're going to talk about some of the potential changes to that criteria. So the committee that is writing up the 2024 criteria actually started meeting in the fall of 2023, and they discussed what changes need to be made or what things should we include. And I am not part of that committee, so I do not have the answers to what is going to come. But I do know that they discussed several things, and some of them are listed here, not everything, but one of the things on their list was, is dissemination in time needed to diagnose MS? And I think that's going to bring us back to more people getting that diagnosis earlier and getting on medication sooner if they have the typical topography of MS. Also, there was talk about including the optic nerve as one of the common areas for MS are typical. The old criteria does not include optic nerve as a site for like CIS. It also will most likely include RIS and when to treat that, so that will be included. And then there's also talk that maybe the central vein sign or paramagnetic rim lesion will be included in some of the criteria. The use of diagnostic markers like kappa-free light chains are also considering, may end up on the criteria as well. And then neurofilament light chains may also end up on there. So we should have the new criteria at ECTRIMS in Copenhagen in the fall. And so be on the lookout for the changes there. So benefits and limitations of treatment. I think there are lots of benefits, and I think everyone in this room could list the benefits out without any difficulty here. The limitations are also already covered today. You know, these medications don't come without risk. And then even in this day and age where we have high efficacy treatments, there are individuals that still can have breakthrough disease and may need to switch medications or have even higher efficacy medications if they're breakthrough a lower efficacy treatment type thing. So some individuals have poor compliance, which we've already discussed today, or intolerability to certain medications due to side effects. And then you have a group of individuals that are resistant to treatment altogether, and they want to approach it with a holistic approach like diet without being on a disease-modifying therapy. So nuances of progression. And again, I said I inherited this outline, so I kind of had to go with what was there. And I struggled with this because I don't feel like there's a clear-cut answer to this. Everyone is different, and how one patient presents with progression may be very different with another. And in clinical practice, I've seen patients with clear progression, and it varies so much patient to patient. So I don't have clear-cut guidelines for you on that, but I think it's important to talk to our patients and listen to them. They're going to be able to tell you how certain things are getting harder for them, or maybe changing, or symptoms that have come up outside of a relapse, things like that. And then I think it's really important to look and rule out other causes. I cannot count how many times I have seen a patient who, they said, oh, my MS is so bad, it's really, really progressing. And we talk through it, and it's not MS. They have lumbar disc disease or a cervical disc that's pushing and causing symptoms. And so don't always assume it's their MS. They need to be worked up for other things as well. And so sometimes we get lucky and we can tell them, well, I have good news for you. It's not your MS that's causing this, and maybe it's not truly progression. We need to get you in with orthopedic or whatever it may be. So talking about progressive MS, the secondary progressive MS, that's how it's been labeled since I started in MS. And now there's this new term that came out a couple years ago called smoldering MS. And looking at this and reading up on articles, it's hard for me to separate it from secondary progressive. I really feel like it's just a new term for secondary progressive disease. And it is progression independent of relapse activity, and where disability will accumulate over time without any MRI change. This is thought to be driven by microglia that is causing a neurodegeneration in the brain. So with smoldering MS, it is multifactorial. There's many things that affect this phenomenon, and those are included here on this slide. Things like lifestyle factors, immune responses. And you can see how the degeneration occurs. There's this active phase, and then a delayed relapse associated neurodegeneration, and then a post-inflammatory neurodegeneration, all occurring months to years after the initial attack. So the big question with smoldering MS, or secondary progressive MS, if you will, is can we target it? Are there going to be treatments that actually work in this situation? And I hope the answer is yes. I hope that in the next year or two, we will have that answer and we'll be able to say, yep, we can slow that down as well. And not only is MS a manageable condition for those we catch early, but for even those that didn't get an early diagnosis. So another hot topic is aging in MS. So one of the reasons why this is such a hot topic is we are seeing older individuals. People are living longer with the condition. We have the baby boomers who are aging. And so we're treating a lot more individuals who fall into that older population. And with new and emerging treatments that have been approved, you're seeing a lot more patients on these medications at an older age. There is no clear data on this population. Over the age of 55, they were excluded from the pivotal trials. So we don't have the data on how to manage these individuals long-term, what the safety and efficacy of these medications are in this population. So that is definitely something that future directions will need to go. Aging affects several things in the body. We'll talk about immunosenescence here in a second, but aging definitely affects the infection risk, the body's autoimmune response, and then your number one risk for cancer is age. As age occurs, it is the higher risk for cancer increases. So there's many factors when deciding to continue or discontinue a disease-modifying therapies for this population, and unfortunately there are no clear guidelines. There is a trial that came to an end, I think it was 2023, and that's the DISCO MS trial. We'll go over those results here in just a minute. But immunosenescence is the body's natural response to aging. It's what the immune system does as we age. And there's many things driving immunosenescence and lots of moving parts with it. And I'll show you a slide here in a second that kind of goes over what happens to each type of immune cell during immunosenescence. But it's thought to be kind of driven by this progressive thymic involution that occurs over time. And another factor here is remyelination. So early in the disease process, we know that individuals do better with remyelination, and later on, they have a much more difficult time with this. So this slide is very busy, and I'm not going to go into great detail on each individual thing, but just know that immunosenescence affects the T cells, the B cells, and the natural killer cells here. And this can have an effect on the patient. There is a poor vaccine response due to these changes. There's an increased production of pro-inflammatory cytokines that occur, and there's a deterioration of the immune response and more trouble fighting infections in this population. So the DISCO MS trial, that's the trial for 55 and older that was done, and the results are included here. So in order to participate in the trial, the individual needed to be 55 years of age with no relapses in the past 5 years and no new MRI lesion in the last 3 years, and still taking an FDA-approved DMT. They looked at 259 individuals, and they found that In the continuation group, so they split them up. There was the people who continued on the medication and those who discontinued. 4.7% went on to have a relapse in the continuation group, and then 12.2 in the discontinuation group. So side effects and adverse events were similar in both groups. And what they also found was that 15 of the 22 individuals that did have new lesions, they did not have clinical symptoms, and they did not report changes in disability. So what can we take from that? So the recommendation from this trial is discontinuation of disease-modifying therapy might be a reasonable option in patients older than 55 years who have been stable for 5 or more years. And before you decide to stop someone on medication, I think it's really important that you discuss with them that in that clinical trial, although there was a recommendation to discontinue or consider discontinuation after 55, you do have to let them know that there was a higher risk of a relapse in those who did discontinue, and it needs to be a shared decision to come off of medication. There are 2 trials that are ongoing right now, and we should have answers in 2028 looking at individuals who are no longer on MS treatment. All right, so benefits and risk of ongoing treatment in these individuals. There's multiple sets of recommendations from various sources, but none of them are really clear-cut. There's no clear age to discontinue. I work in a very large MS center. We have numerous neurologists there that vary on when they decide to discontinue treatment. Some are more conservative, and others, kind of fall in that 55. They start having the conversation with patients at 55. So it varies greatly, and there's no clear guidelines on what to do. Discontinuation should involve shared decision-making and a risk-benefit discussion with each individual person. And then most recommendations include ongoing follow-up and monitoring, and patients should be counseled on the importance of this ongoing monitoring. All right, so we're going to do a couple case studies, and that will be the end of my section here. So Susan is a 58-year-old white woman with a 20-plus year history of MS. She's been stable without a relapse for the past 8 years on natalizumab. She's been doing some online reading and asked you today if she should stop her DMT because of her age. She is worried about a future relapse. Which answer best fit how you would respond? Would you A, stop natalizumab because she's over 55 and has been stable? B, consider de-escalating a DMT to teriflunomide and monitor for the next few years before discontinuing? Or C, discuss the risk and benefits of treatment with Susan and together come to a shared decision regarding future treatments, monitoring, and follow-up? Who would do A? B? What about C? Okay. All right. I don't think that A or B are necessarily wrong. I think it needs to have a discussion along with it. I think in this situation you could consider stopping the natalizumab. You could also consider de-escalating DMT to another medication. And either one, I think you just need to talk with the patient and decide what their goals are and what kind of risk profile they're willing to take as they age and as they have more things going on behind the scenes. Do they want to continue on the same treatment, or do they want to de-escalate, or do they want to stop altogether, and what kind of risk would that entail? Okay, the last case study here. Joan is a 55-year-old white female with MS who presents today for a follow-up visit. She's been on ocrelizumab for 3 years and has not had any acute relapses in at least 5 years. Despite this, though, Joan has been having a harder time with cognition and walking. She has needed to go from using a cane to using a walker and reports several recent falls. She is needing to have her spouse help her keep up with her appointments. So what terms would be best appropriate to educate Joan and her spouse about? So who wants to say A? B? C? D? Okay. Yeah, so Joan is 55, and so she does meet that criteria that we just discussed with the DISCO MS trial. But Joan is one that I don't think I'm ready to have that conversation of stopping treatment on, mostly because of the progression that I'm seeing. So I don't think I would mention, I mean, I do need to talk to her about immunosenescence, but that's not going to be the main goal today. She's not having infections. The main goal today is going to be educating her on why she might be seeing some of these changes and trying to figure out strategies to help with it. So that is the end of my talk. I know it was a lot over a short amount of time. So is there any questions that anyone has on RIS, CIS, progressive, smoldering, or changes to upcoming criteria?
Well, I have a question. So in the arena that we're in now with all of these treatment options for patients, do you find that your clinic has changed in the amount of time that you're needing to sit down and talk with patients? Are you trying to do that in one visit? If they're coming from a great distance, are you scheduling them for a second visit?
So we do a lot of telehealth in our clinic. So when COVID hit, we were the only clinic at UT Southwestern that had already started telehealth before COVID. And so during COVID, we did a lot of telehealth. And so we try to break it up. So we'll have the discussion with them in the visit. And then if they're not able to make a decision that day, we'll say, you know what, let's have you reschedule a telehealth in 2 weeks or 3 weeks, and you know, you have time to go home and do some research, and then we'll meet back up and discuss this again and come to a decision. Or we might send for labs in between, kind of see what those labs come back, like a JC virus, or you know, ruling out things like Hep B and things like that before we have the conversation. But yeah, we do it in a series usually because we only have 30 minutes.
Go ahead and invite Erica Goff to come up with us. Come on up. And Erica has been at University of Alabama. She started there in some of the inpatient units and worked with neurology, and then she transitioned over to our MS specialty clinic as a specialist pharmacist in 2016, I believe.
That's right.
So I'll let her tell a little bit about what her role is. And for those of you that don't have a specialty pharmacy person that works with you in your clinic, I can't tell you how wonderful she is and the clinicians that are there, and certainly our patients and their care partners. And no, you cannot talk with her about coming to your center. So she's not looking for a job. Thank you.
Thanks, Bev. All right, hey everyone, my name is Erica. I'm the MS pharmacist at UAB in Birmingham, Alabama, where I work in the outpatient neurology clinic. And today I will be presenting on brands, generics, and biosimilars, the pharmacist's approach to emerging treatment options. So I have one disclosure. So our objectives today will be to review the multiple sclerosis disease-modifying therapy timeline, describe the drug approval process, review generics and biosimilars, describe the pharmacist's approach to navigating medication treatment options, and review the impact and benefits of pharmacists. So for ease of understanding, I have listed brand names on this slide. So as Dr. Rinker reviewed, our first disease-modifying therapy, Betaseron, was approved by the FDA in 1993. So many new disease-modifying therapies have been approved since then, including our first generic, glatiramer acetate. Since then, we now have dimethyl fumarate, fingolimod, and teriflunomide. And then last year, our first biosimilar, the natalizumab, was approved. So as you can all see, we have many treatment options. So let's take a step back to see how these medications were approved. The drug development process is long, complicated, risky, and expensive. Drug products must go through this rigorous process to make sure they are both safe and effective before they reach the public. So first we have discovery and development, then preclinical research, clinical research, FDA drug review, and the FDA post-market drug safety monitoring. So research for a new drug begins in the laboratory. The goal here is to discover a new compound, DNA, RNA, protein, that interacts with a chosen target that could be beneficial for a certain disease state. Thousands of compounds may be tested, but only a small number may warrant further study. So once a promising compound is identified, researchers conduct a series of early in vitro experiments. So next, we have preclinical research. So before testing in people, researchers will conduct studies either in vitro, in test tubes or petri dishes, or in vivo in animals. The goal here is to determine if a compound can cause harm or not. This step also looks at pharmacodynamics, which is the drug's effects on the body, pharmacokinetics, how the body interacts with the drug, stability, bioavailability, and administration method. All of this data provides detailed information on the safety and efficacy of a drug. So if the researchers think that this compound is promising, they'll submit an IND or an investigational new drug application to the FDA to see if it's ready to be tested in humans. All right, so clinical research. So this tests the safety and efficacy of compounds in big groups of human volunteers. So phase 1 trials involve a small number of healthy volunteers, and this lasts several months. The purpose of phase 1 is safety and pharmacokinetics, which again looks at how the drug is absorbed, broken down, and excreted in the body. This also evaluates the side effects that may occur at different dosages. So phase 2 expands to several hundred volunteers with the disease state or condition. This phase looks at the clinical effects of the drug in the treatment population and determines an ideal dose. So phase 3 studies are conducted at multiple centers and involve thousands of patients with a disease or condition. So this large-scale testing provides investigators with more complete data about the drug's safety and efficacy by comparing the experimental drug to placebos or existing approved drugs. If phase 3 is successful, investigators can seek FDA approval to market the drug. Here we go. All right, so in order for a drug to become FDA approved, the sponsor must submit an NDA, which is a new drug application, which includes all the scientific data the company has collected. Items such as proposed labeling, safety, patient information, and directions for use. So after an NDA is received, the FDA has 60 days to decide if they want to file it to be reviewed. So the FDA will do a full review of the clinical data, animal studies, and inspection of clinical study sites. The review team will make a recommendation, and the senior FDA official will make a decision. So if the FDA determines the drug is safe and effective for its intended use, they will work with the applicant to develop prescribing information or labeling. The FDA will then review that labeling to ensure that the information is appropriately communicated to both healthcare providers and patients. And it's important to note at any time if this applicant disagrees with the decision, they can file a formal appeal. All right, and last but not least is the step 5, FDA post-market drug safety monitoring, also known as phase 4 studies. So it's not possible to predict all of the drug's possible side effects during clinical trials. So these phase 4 studies gather additional information about the safety and efficacy of a drug after it's approved in the real-world setting, which allows for a true picture of the drug. The drug company is required to submit periodic safety updates to the FDA, which allows them to take action when needed. So in order to protect significant efforts and investments, pharmaceutical companies rely heavily on patents. So these patents last 20 years from the date on which the application was filed, and so this is why you may see some variety in patents. So for example, if a patent application is filed, it then takes 10 years to get the drug approved, the patent will only last for another 10 years. So once the patent expires, other companies are allowed to release generic formulations of their product. And these generic companies are smart. They're not waiting around until after the patent expires to start developing a generic. They begin developing their generic product years before the patent expires so that their product will be ready to hit the market as soon as possible. All right, switching gears a little bit, we're going to talk about generic medications. So these generics are pharmaceutically equivalent and bioequivalent to the marketed brand name drug. So what does this mean? So pharmaceutically equivalent means they have to have the same active ingredient, strength, dosage form, route of administration, indication, safety, and quality. They also must be bioequivalent. So this means the same amount of drug must enter the bloodstream at the same amount of time. They also must have appropriate container, labeling, and manufacturing. So generic medications also go through a rigorous process to ensure that they are safe and effective and that they can be substituted for their brand counterparts. So as opposed to brand companies filing NDAs, generic companies file ANDAs, or abbreviated new drug applications, to the FDA for generic approval. They're termed abbreviated because they do not have to conduct those lengthy and costly animal and clinical studies that are required for NDAs. So instead, generics must demonstrate that their product performs in the same manner by conducting bioequivalence studies. So to determine if a drug is bioequivalent, we look at bioavailability. So bioavailability is the extent and rate to which the active drug ingredient is absorbed and becomes available in the body at the site of drug action. This is measured by looking at Cmax and AUC. So the Cmax is there at the top of the curve, and it's a measure of the highest concentration of drug in the blood. And AUC is the area under the curve, and that's overall drug exposure over time. So in order for a generic to be bioequivalent, it must prove it releases the same amount of active ingredient into the bloodstream at the same time. So the FDA requires Cmax and AUC to lie within 80 to 125% of the brand values to be considered bioequivalent. It's important to note this rule also applies to brand comparisons, which can also vary with each batch. So for example, if the mean AUC of the branded product is 100 units, that means the AUC of the generic product must lie between 80 and 125 units. So these bioequivalent studies are pharmacokinetic crossover studies that allow comparison within individual subjects. So study A will receive the test product, and blood will be taken to measure those PK values. Afterwards, there'll be a washout period, and then that subject will then cross over to receive the branded product. So here's an example of a bioequivalent study of teriflunomide, looking at the plasma concentrations over time with the branded product in 14 healthy individuals. The blue line there is the branded product, and the red is the generic product. So as you can see, both lines are very similar. So according to the results, the lower and upper limits of the AUC there on the right are 93 and 107, while the Cmax values were 92 and 108. So these values are all in that predefined range between 80 and 125, therefore demonstrating bioequivalence. So let's look at another example. So this study looks at the plasma concentrations over time of monomethyl fumarate, which is the active ingredient of dimethyl fumarate, in 23 healthy volunteers. So the branded product is the red line, the generic product is the blue line. So again, both lines follow a very similar curve. the lower and upper limits of both AUC and Cmax values of the generic, again, there on the right, are between 98 and 103, and they are within that predefined range of between 80 and 125%, therefore demonstrating bioequivalence. So just because brands and generics are both bioequivalent and pharmaceutically equivalent does not mean they are the same in every way. So they're going to have different excipients. And so this means inactive ingredients such as binders, fillers, diluents, and dyes. They're also going to have a different appearance. And this is because trademark laws in the United States do not allow generics to look exactly like their brand counterpart. There will also always be a slight but not medically significant level of variability. And this can be comparable, again, to one batch of brand medication with the next batch. When medications are produced in mass quantity, very small variations will exist. However, it's important to keep in mind that drugs such as anti-epileptics with narrow therapeutic indexes may be affected by that. So on average, generics also cost less. Again, it's because these generic companies don't have to spend a tremendous amount of money on those animal and clinical studies that the brand companies do. All right, switching gears again, let's talk about the biological products. These are large, complex molecules that are made from living sources, such as bacteria, yeast, plants, or animal cells. This is different from generics because those are small molecules, chemically synthesized and structurally identical. So some examples of biologics include vaccines, blood products, proteins, and monoclonal antibodies. And you can see there that picture, how tiny that aspirin is compared to the monoclonal antibody. So a biosimilar is a biologic medication that is highly similar to the FDA-approved reference product. This means they're made from the same type of living source. They have the same function, pharmacokinetics, pharmacodynamics, safety, and efficacy, with no clinical, meaningful differences in purity, potency, and safety. So because these active ingredients are larger and much more complex, they cannot be copied exactly. This also makes biosimilars more difficult to manufacture. There's usually a slight variation because these products are a mix of living sources. So unlike a generic product that can be substituted unless otherwise specified by a prescriber, biosimilars are not automatically interchangeable. In order for a biosimilar to be interchangeable, it must go through an additional interchangeable study that shows the same clinical result as a reference product in any given patient. If it's indicated for multiple administrations, the interchangeable must be able to be alternated with the reference product without loss of efficacy or side effects. So the biosimilar approval process is different than its reference biologic. So analytical studies are the foundation of biosimilar development as opposed to clinical studies. These studies provide data about the structural and functional similarity of the biosimilar to the reference product. Analytical studies are supported by preclinical animal studies that provide toxicology and safety data. There are also some clinical studies, which include immunogenicity studies to assess a patient's immune response to the biosimilar, and pharmacokinetic studies to demonstrate the biosimilar moves through the body in the same way and is as effective. The bottom line here is much more time is spent on the analytical studies. So, as we previously reviewed, brand companies file NDAs for brand approvals, generic companies file ANDAs for generic FDA approvals, biosimilar companies file 351(k) applications for biosimilar approvals. So these applications must include information demonstrating the biologic is biosimilar to the reference product. It must also have the same mechanism of action, indication, route of administration, dosage form, strength, and the manufacturing facility must meet those FDA standards. So biosimilar names, they include the branded product's core name and a unique 4-letter lowercase suffix that is devoid of meaning. So these suffixes are used to distinguish a biosimilar product from the original brand product. And these suffixes should not be promotional, they should not resemble any other product suffix, and should not resemble the brand product in any way. So here are some examples that you may have seen of biosimilars. Then here is a pharmacokinetic example of the newest biosimilar for MS, natalizumab, SCTN. This study included 453 healthy participants, and it compared plasma concentrations over time between the natalizumab biosimilar, their European-approved natalizumab, and the United States licensed natalizumab. So looking at the chart, the orange and yellow lines are the reference products, while the blue line is the biosimilar. So they all basically overlap with each other. And the results from the PK data there on the right show the AUC is 0.91, and it goes up to 103 there on the right. And it's in that pre-specified range of between 80 and 125%, which demonstrated biosimilarity. All right, so again, here is what we have right now for our MS-DMT generics, glatiramer acetate, talking about the fumarate, fingolimod, and teriflunomide. And then our newest biosimilar, natalizumab, SCTN, which is approved and should be coming to the market soon. All right, and so some benefits of branded and generic medications, and this is definitely not a one-shoe-fits-all category, but for the most part, in my experience, brand medications have those patient support programs that we rely heavily on. They provide financial assistance, such as copay cards, patient assistance programs. They have bridge programs, so they can supply medications for free to patients that are having issues with insurance approvals or, just any type of interruption in therapy. They also have nurse educators that can provide injection training and just follow up the patient. They can also complete baseline labs and assessments at the patient's home. It can complete benefits investigations if needed. So some benefits of generics, they can be less expensive. They're usually preferred by insurance companies, which allows for faster approvals. There's usually no paperwork or start forms. Cost Plus Drugs is a great option, and that's an online pharmacy that can provide generics at a really affordable cost to patients. And then an additional benefit is that generics motivate innovation and inspiration for drug companies to research and create new medications. So some challenges with the brand medications include the approval process. If they have a generic counterpart available, it can be harder to get those approved. I put patient support programs on here because there can be some challenges, including filling out those start forms and trying to get patient consent if the patient's already at home and you're trying to track them down to get that submitted. There can be a lot of back and forth with the reps, and sometimes the prescriptions can be triaged out to the patient before the patient's actually ready to start on therapy. Some issues with the generic medications can be affordability issues. A lot of times there's a lack of copay cards and patient assistance programs. There's also no assistance with labs or assessments, and there's no bridge supply programs. So where do pharmacists fit in with all this? Clinical pharmacists work as part of a multidisciplinary team in the MS clinic. We work directly with the providers, nurses, and patients. And at UAB, we have patient care coordinators that assist with test claims, refills, and billing with our specialty pharmacy. Working together enables us to achieve optimal patient outcomes. So like I said, we're an essential part of the healthcare team. Some roles include, but are not limited to, medication access. So again, submitting those PAs, appeals, counseling patients, injection training, getting patients enrolled in financial assistance, med recs, ordering labs for patients. We proactively follow up with patients, which allows for side effect management and adherence monitoring. We also can share information quickly with the providers and assist in coordinating care. So the center of the pharmacist, and really any healthcare provider's approach to navigating patient access is the patient's best interest. So after our physicians and the patient discuss treatment options, I'll have a conversation with the patient about their choices. So do they prefer orals to injectables? Are they worried about a certain side effect? Will they be able to keep up with the laboratory monitoring? I'll then provide education on their chosen disease-modifying therapy. Now, if that chosen therapy has a generic counterpart, I always review generics are also safe and effective. Some patients are scared to try generics because they think they will not work as well. Another huge consideration is insurance. If there is a generic available for the chosen therapy and there's no compelling reason for the brand, we usually start there. This also allows for easier approvals down the road if preferred agents are used initially. And like I mentioned, sometimes with generics, affordability can be a huge issue due to lack of financial assistance and copay cards. So if patients cannot afford their medications, they're not going to take them. So in this scenario, we may push for a brand counterpart that has a patient assistance program. And then last but not least is the patient support programs. A lot of times patients won't decide what they want to start on in clinic. Some live far away in rural areas. So having a patient support program that provides at-home assessments, labs, and nurse training can be highly beneficial. So I threw in a case here. So RR is a 42-year-old female with commercial insurance who was diagnosed with relapsing remitting MS when she was 28 years old. A diagnosis, she was started on a brand name disease-modifying therapy. So this year, a generic alternative was approved. Her insurance is now requiring that she switch to it. RR is very hesitant about switching to a generic. So how would you guys respond? Right. I would try to be empathetic with the patient. I wouldn't say, well, tough luck, you're going on it. You know, they want to feel like they're understood. So I would say, I understand your concerns. It sounds like you are worried that the generic will not work as well for you. And, I wouldn't want you to take something that is not as effective either. So I would then review, generics are also safe and effective. They're carefully, tested by the FDA to make sure of this. They have the same active ingredient, the same strength. They even go as far as to make sure that active ingredient is going into your bloodstream at the same amount of time, at the same site of action. So then I may also add, what if you tried this generic for 2 weeks? If you notice any side effects or if you feel like your MS is worsening, let us know, and we can definitely fight with the insurance company and push for that brand name to get approved again. Patient case number 2. JR is a 33-year-old female with commercial insurance. She is starting on a generic disease-modifying therapy. The PA is approved, prescription sent off to the pharmacy. JR calls your office saying her disease-modifying therapy copay is $250, and she cannot afford this. So any ideas on what you would do?
Mark Cuban.
Yes, that's one of the options, Mark Cuban. Always check Mark Cuban. They make sure it's affordable and also make sure it's in stock. That's a big thing. Sometimes they've been in and out of stock with certain products. So that's definitely a great option.
One option I've seen this week is if Mark Cuban doesn't have it in stock, they give the patients a card they can use at a commercial pharmacy.
I did not know that.
Teriflutamide this week.
Okay, that is great to know. So she was saying that if Mark Cuban is out of drugs, they will give the patient a card to take to a local pharmacy to get the medication. So I did not know that, so thank you for that. Any other ideas? One thing you could do is see if the generic does have a copay card. Like I said, not all of them do. There are some, they're not as good as the brand name. Some of them max out at like $50 a month, and some of them are hard to get. Just because of that certain generic, but I would see if they have a universal copay card. And then if neither of those are an option, just, we would try to push for maybe a brand product that has a patient support program. Usually if their insurance company will not approve it, if we get 2 denials, we can get them on the patient assistance program. So in conclusion, having a pharmacist in your clinic will lead to better outcomes. Pharmacists can provide services in clinics such as patient education, submitting PAs, appeals, peer-to-peers. We provide proactive follow-ups with patients, which will free up time for the nurses and physicians to focus on other things. Patients benefit by having improved medication access and reduced financial burden. We can simplify the oftentimes complicated navigation process through generics, brands, and biosimilar options, leading to increased satisfaction all around. Here's my contact information. Here's my references. And that's all. Be happy to answer any questions. Yes. Mm-hmm. Yeah, I agree. I'd be happy to assist with that, if there's have any ideas. Be a good project. Yes.
So we have had in Indiana, where I work, we have had this most amazing pharmacist in our nursing clinic. And this year, the powers that we decided that we did not need that anymore. And it's a huge loss for our patients. So I wonder if I could reach out to you to make the argument to them how dumb that is.
Yeah, I mean,
Back to us.
yeah, there's just, multiple studies about all the cost savings, even if they're just looking at, that.
Looking at dollars.
Right, and, I would say, look at these studies. I'll be happy to send you some that some of our colleagues have done about the benefits and impact of pharmacists in clinic and how they really do save money. Yeah. Oh, one more over here.
I'm fortunate enough to have a PharmD on my team, and no, none of you can have her. But I noticed that sometimes she has to prove her worth.
Mm-hmm.
How do you do that? How do you, I don't know if there's anybody here who doesn't have one on their team, like literally seeing patients in the clinic. If you're already doing it, somehow you've got your foot in the door. How does someone actually open the door at all to have that?
Well, at UAB, we're a big health system, and so we were lucky that we have our own specialty pharmacy. So I'm a part of them, but I'm also in the clinic, so I'm kind of a hybrid of a specialty pharmacist / clinic pharmacist, so that funds my role. But I know outside of that, getting involved with research, pharmacists can assist with that and get those research grants in to fund money, collaborative practice, billing, if your state allows that. And then again, just, maybe just showing these studies that pharmacists save a lot of money and can be, very impactful. Yes.
Piggybacking off of hers, but how can the pharmacist get more integrated into the clinic? I think more on like the patient side. Our clinic has a pharmacy.
Yeah.
Pharmacist is pretty much just in the pharmacy.
If they have time for that, because again, my role, I'm not in the pharmacy at all, so I'm just sitting in clinic. I have, the retail pharmacy they are involved with all the filling and stuff. But what I did when I first started was, I just walked in and I just said, hey, Dr. Rinker, my name's Erica. I'm the new pharmacist here. Same with the nurse, and I just kind of sat there and tried to help out. And I feel like the longer time I was there, the more they were kind of willing to be like, oh, well, you can do a PA, here you go, or you can do a start form. And then, just over time, just, showed what I could do. And that was 8 years ago, so.
So, I go back to the days where nurses did everything, or we had a medical assistant, or the secretary back in the office. So I think that there's been a mind change for all of us as roles have continued to change. And, one of the things that I've said to a lot of folks, this is a business. I mean, we're in patient care, but you've also got to look at the time that is involved. And if you can take maybe the nurse away from having to do some of the pharmaceutical education and get back to maybe symptom management, discussing, family situations. We don't practice with a nurse practitioner at UAB, physician kind of role there. But when you hear about clinic visits being 15 to 20 minutes, and think about what all you've got to be able to do in that time, or if you've got the luxury of 30 minutes, but, you know, looking at who is doing what, almost, you know, like a work balance. How do you manage with the clinic having so many clinicians? Do you see patients in the clinic, or do you take them somewhere else?
So that's a good question. If I'm in clinic and the patient's ready to be seen, I will see them in the clinic whenever possible, especially with the new starts. I also schedule follow-ups and, you know, to coincide with those patient visits. However, a lot of times, like I had mentioned, patients don't decide what they want to start on. They go home and think about it. You know, 2 weeks later, they'll call us. So I will also talk to them on the phone at that point. So it is a hybrid of calling on the phone, and then I'll have, you know, they can talk for hours at that point, or just, you know, try to get in and out of clinic.
Are you gathering information for the clinic about the biosimilars, about the generics and things like this so that you can maybe present this in the future? Are y'all looking at anything like that?
We're not at this time. It's a good project to look at. We haven't had any issues with generics as of yet. I don't anticipate it, not to say it won't happen. But yeah, I think that would be a great project, you know, going forward, looking at the new biosimilar coming out and comparing it to the brand.
Any other questions, comments? All right, well, we're running a little bit early. I don't think y'all will mind that, so we're going to go ahead and slide into our next topic. Thank you so much, Erica.
Thank you.
Excellent. So, as I said whenever we introduced what our day was going to be like, you know, I think that we all embrace a multidisciplinary clinic. And I think that, you know, we may all come from different clinic settings and what we have available. You know, we ourselves did not work directly with a dietitian there at UAB. We have folks that we are able to call on. And I think that, you know, again, when you are looking at seeing patients 15, 30 minutes, who else can you get involved to look at that patient with you? So we have Mana Bostic with us today. She is a registered dietitian nutritionist out of Greensboro, North Carolina, and she and others are starting a specialty group here at the consortium. You know, I think she'll probably cover a little bit about that, but also just what she can bring not only to us here today as education, because I think there's a lot of questions that I have as to what you could possibly offer us. And when we look at our patients and especially comorbidities in our folks and how a dietitian can also help us with that and just encourage that wellness and that we can bring back to our patients and our families. So I'm very thrilled that Mana agreed to join us for our session today. So welcome.
Absolutely, and I just want to thank you very much for including a registered dietitian in this important conversation about the fundamentals of MS care. And as Bev mentioned, here at the consortium, I am the chair of a newly formed special interest group, and that is for dietitians who work with people living with multiple sclerosis. So I mention this for a couple of reasons. If you either have a dietitian in your clinic or you have one peripherally that you refer to, please refer them to the CMSE website, the special interest group pages where they can join at no charge. We are getting started with quite the robust to-do list, but preliminarily we would like to, first of all, grow our membership and make sure that there is a list of dietitians available who are MS aware or MS trained specifically that can answer questions and potentially that you could refer to should they be in either your area or your insurance coverage area. Because that is something that a lot of people don't realize. Dietitians are covered by insurance widely, and so that's an important thing to remember. I want to point out, though, that everybody seems to be, I don't know has anybody in here had a suggestion from a coworker, a neighbor, somebody at church, here's what you need to be doing with your diet, right? I mean, so and I'm pretty sure we've all experienced that, but it's even more overwhelming if you live with a chronic illness like multiple sclerosis. And the problem with that is I'm here today to kind of provide some distinction between clickbait nutrition advice as opposed to what I do as a profession, which is clinical nutrition. It's really important to remember that it's not just about counting calories, losing weight, or avoiding all of these foods on this really long list, or eating copious amounts of these other foods, which are on another arbitrary list. The truth is that the study and practice of human nutrition is a complex and nuanced issue, and it requires context. And context and nuance are things that are just seldom ever discussed or provided in the context of clickbait nutrition advice. But before we get started on specifically what is clinical nutrition and what my colleagues and I do for a living to help folks with MS navigate the nutrition superhighway, I want to talk about, remember why we as humans eat food in the first place. The primary purpose of humans eating food is to sustain life. It's a basic human need for survival and health. And the nutrients that we get from food have three primary roles. Those include the food provides energy in the form of calories, which is different from being energized. A lot of people want to know what foods will give me energy, and I say all foods give you energy in the form of calories. That's different from them being stimulated, which is what you get from caffeine. So, those understandings of the language are often challenging for some people. And they contribute to body structures, our cells, our muscles, organs, bones, everything that we have. That's a really important thing. And they regulate chemical processes that go on in the body, including metabolism, nerve transmission, fluid balance, muscle contraction, and so much more. In other words, our bodies require food to function. And so eating to support this important requirement is an integral, fundamental, foundational part of being a healthy human. The questions that are kind of circulating out there is that, do these three primary roles of food change after receiving a multiple sclerosis diagnosis? Do people with MS no longer require energy? I say we still do. Do people with MS still have body structures that require support? Absolutely. And the bodies of people with MS still have those chemical processes going on that are in need of regulation. So I would argue that the three primary roles of the food that we eat are the same after our multiple sclerosis diagnosis. So based on the currently available evidence, the fundamental role that food plays in our human health has not changed. And before we move any further into the clinical stuff, I want to ask you to see, what else do you notice about what's going on in these pictures? They're all eating food, but they're enjoying their food. They're having a joyful family experience with family and friends. And that's an important thing that gets overlooked, especially in the conversation about eating with a chronic health condition. It tends to become kind of punitive and over-medicalized, taking away the fact that traditional foods are at holiday time. You're supposed to, I can tell you that as a dietitian, the talk that I am least interested in giving is the one at the holidays, telling people with MS how to not enjoy their holiday foods. Because as somebody living with a chronic illness, you still deserve to have those joyful food experiences, right? And a truly healthy eating pattern recognizes this and is built around food that is both physically and emotionally nourishing. So with that covered, let's move on. What is clinical nutrition? I've got here a quick graph of the scientific method because that is just like what you all do, that's kind of where my work stems from. The nutrition care process is a comprehensive evidence-based framework that registered dietitians use to provide personal nutrition care to patients and clients. Nutrition care process utilizes medical nutrition therapy. So that's, if I see a patient, whether it's in a hospital or in an outpatient clinic or in my own private practice, what I'm doing with them is called medical nutrition therapy. And that is utilized to ensure that Registered dietitians provide high-quality, personalized, or individualized nutrition care tailored to every individual's unique set of needs, circumstances, and goals. And I'll talk a little bit more about the specific MNT, or medical nutrition therapy, in just a minute. But before we do that, let's differentiate that just a little bit from clickbait. And I mean, has anybody been introduced to clickbait, right? Have you been on Facebook or the internet and you've seen what clickbait is? And so a lot of people, especially in our patient population, get nutrition information from those sources. Clickbait can be defined broadly as sensationalized headlines claiming that diet can heal, beat, or reverse multiple sclerosis or any other number of maladies and illnesses. They're usually based on articles that have been cherry-picked to support nutrition claims. They utilize oversimplified language and promise solutions to really simple solutions to very complex problems, right? Avoid gluten and your MS will be 100% better, right? And often this advice comes from unqualified wellness experts, lacking any nutrition education training or credentials, or it may be from alternative health providers using diet in unconventional ways, or it could be because of the most print media kind of going away. The internet how do we charge for our information now? It's cost per click. So sponsored content prioritizing product promotion over evidence. And who creates clickbait? Clickbait is going to be the content purveyors and wellness influencers who are trying to earn money from the clicks. And it can be also Dr. Google et al. Who are trying to sell their products, promote, products and services. And why is this a problem? This is a problem. This chart will hopefully try to illustrate that. This 2015 paper used social listening to understand the concerns and interests of the MS community by analyzing trends and conversations across traditional media, social media, website traffic, and the calls to their information resource center. The red bars on here indicate alternative treatments such as cannabis, exercise, vitamins, supplements, and diet. Right there at the top. A lot of interest in diet. The blue bars represent traditional treatments like Copaxone, like all the pharmaceuticals that we just went over. Alternative treatment topics, particularly diet, are mentioned more frequently than traditional treatments in these forums. And you may have noticed that folks with MS have a significant interest in the role of diet in treating or managing multiple sclerosis. I believe somebody just a moment ago mentioned that some people preferring to abstain from the pharmaceuticals for a more holistic management. But it's important to remember that nutrition is not an alternative treatment. It's just not. Diets may be promoted to be an alternative treatment, but those diets are just not therapeutic in nature. And this paper goes on to identify some gaps in knowledge and suggested areas for future research to better support the wellness needs of the MS community. And research in this important area is ongoing. But in the meantime, our patients still have questions, am I right? Is there anybody in here who hasn't received a question about nutrition in some form or fashion? So it's an important thing. And maybe you have questions about that yourself. But something that this paper talks about also is that when our patients feel that their questions are not being fully answered by doctors, they often seek guidance from others, which this paper would suggest could be a problem, and I agree with that entirely. This is kind of the bane of my professional existence. Before I get to talk about anything that is of clinical value, I have to spend so much time busting the myths before we can even get started. But I digress, I won't go into that. This paper also discusses the trend towards decreased trust in pharmacological approaches, as well as an increased interest in more natural approaches for multiple sclerosis, including a shift to in patient preferences towards more holistic and whole-body natural approaches influenced by, again, the alternative medicine modalities which use unconventional nutrition in unconventional ways. And when I use that phrase unconventional, I mean those that are not supported by science. And people doing that include those alternative providers and wellness influencers. And so what fills that gap when we're not being able to adequately address or answer our patients' nutrition questions or concerns? Clickbait is what fills that gap. So I want to now take a minute to talk about what I do as a profession, which is clinical nutrition. I am a clinical nutrition professional, and that I mentioned a moment ago that the framework in which medical nutrition therapy is delivered is the nutrition care process. And for the sake of time, I've not provided case studies today. I want to make sure to point you to a really important conversation we had on Wednesday, where we had a conversation about the role of dietitians in managing comorbidities in multiple sclerosis. And my colleague Tyler Titcomb provides a very well-rounded overview of what this process is, as well as case studies. So, and that was Clinical Course 9 for those of you wanting to check those slides out. Excuse me. But going into it just briefly, here's what I call the Cliff Notes version of this. Is anybody old enough to remember Cliff Notes? I give my age away. So first of all, we assess. You know, it's not just, oh, you have MS, here's what diet you should do. Go away and be done with it. We assess the situation, just like all of you do in your own disciplines, to determine if there is indeed a problem. And if there is a problem or something that we see, we diagnose that. It's going to be the nutrition diagnosis, which is separate and apart from any medical diagnosis that may exist. And then that diagnosis in a chart, if you look in the medical chart, you see a dietitian note, you'll see what's called a PES statement, which is the problem etiology as evidenced by signs and symptoms, the PES statement. It defines the problem. And then we develop an intervention intended to address or alleviate the nutrition problem. And we have nutrition indicators that we use to monitor progress towards that. And then finally, we monitor and evaluate progress over time as the patient implements our intervention. And then we reassess with follow-up meetings while documenting everything in the chart notes so that all the rest of the team can be kept abreast. That's an important thing because if your patient was spoken to, let's say one of you guys or somebody else in your clinic recommended an offhand comment that a patient pursue ketogenic eating or intermittent fasting or something of that sort, and nobody is aware, who's following up on that? Who's determining if there's any consequences of that? Or positive outcomes maybe, but there's just nobody's tracking that. And that is, I would argue that that is a problem. Oops, sorry. So again, this is what the nutrition care process looks like in a big picture of it. But if one of the things that sets registered dietitian nutritionists apart from your lawn guy who could call him or herself a nutritionist is that registered dietitian is a legally protected title. We are bound by a scope of practice as well as a code of ethics. And will not change. There we go. I'm sorry. We are bound by a scope of practice and a code of ethics, which is a really important thing because if your lawn guy gives you advice, he or she is not bound or backed by that. So because I mentioned a therapeutic diet, I thought I'd take a minute to define that and differentiate that from the clickbait diets you might see on the internet. A clinical nutrition intervention is one that controls the intake of, a therapeutic diet is one that controls the intake of certain foods or nutrients, and it is done as a treatment of a larger medical condition, and they are normally prescribed by a physician and planned and overseen by a registered dietitian. Therapeutic diets are modified for nutrients like sodium for for hypertension, fiber, electrolytes, consistent carbohydrate for diabetes and glucose control, as well as texture in terms of food or beverage secondary to dysphagia. Food allergies or intolerances like celiac disease or lactose intolerance. And then if it's warranted, alternative route feeding, enteral or parenteral if they are unable to take food orally. But so the question I'm often asked is there a therapeutic diet for multiple sclerosis? And the answer to that question, at least at this time, is that no, there is not. If we define the problem, so I've got here the problem intervention outcome, which is a simplified version of the PES statement. If we define the problem as multiple sclerosis, there's no intervention that I can provide you in terms of food. You can either, something you can eat copious amounts of or avoid entirely that's going to impact the MS disease process in any way. I say that directly, meaning that I can't make your MS better or worse by what you eat directly. Now, in an indirect way, it's really important to remember that comorbidities play an important role in health outcomes with multiple sclerosis. And where, if we define the problem as multiple sclerosis, there's no nutrition intervention for that. There is a number of nutrition, lots and lots of science to help a person with cardiovascular disease, type 2 diabetes, hypertension, any number of comorbidities that exist out there. And I say this because registered dietitians are not broadly included in the MS care team. And it's really important that at least you be considering referral to a dietitian if comorbidities are a concern. I would also argue that symptom management is something that there are nutrition interventions for many of the nutrition impact symptoms experienced by folks with MS. One specific example that comes to mind is bowel regularity. There are things that a dietitian can help with when it comes to bowel regularity. So it's really important to remember the role of a registered dietitian. Oops. So, is there a consensus? This is a big question I get all the time when it comes to nutrition and multiple sclerosis. Is there a consensus on the role of food in human health? And compared to the amount of research investigating the role of nutrition in human health, the study of nutrition in multiple sclerosis is still relatively new. However, the role of nutrition in human health, there is an existing consensus on that, and that is the Dietary Guidelines for Americans. There is, at this point, as I mentioned before, no indication that MS alters the nutrient needs in humans. There is no consensus that exists on the role of diet in multiple sclerosis. However, it's really important, and this is the good news, the silver lining, if you will, that the Dietary Guidelines for Americans apply to folks with multiple sclerosis. Having multiple sclerosis doesn't mean this doesn't count for you anymore. The problem with that is that clickbait has made it so that our patients don't believe that. They think because they've been told that because they have multiple sclerosis, they must be doing something differently. They need to follow this diet, this regimen, this protocol, take these supplements, and do these things differently. And there's just no evidence to support those claims. So getting the message that the Dietary Guidelines for Americans will help people with multiple sclerosis meet their nutrient needs, those three primary needs which are so important, may be a tough one to get across to folks, but it's an important one. And as I was thinking about this, when I was putting this presentation together, I've seen an advertisement for PNC Bank, I think. Has anybody seen this ad where it says, you know what's brilliant? Boring. Boring is brilliant. Think about it. Boring is the unsung catalyst for bold. What straps bold to a rocket and hurtles it to space? Boring does. And at least as it relates to the bank, they're saying that the dependable, steady information is how you can save your money and then go do that thing in retirement. Same thing applies to nutrition. Eat your vegetables. It's the boring stuff that Grandma recommended will help you to meet your nutrient needs and help you to not so much go on that fancy retirement vacation, but it will help you be a healthy human while living with multiple sclerosis, which will help you have an improved quality of life, health and quality of life. So I apologize to PNC Bank for co-opting their commercial. Which brings me to the dietary guidelines for Americans. Is anybody in here unfamiliar with these? I've recently been informed of exactly how few people in the health space have heard of dietary guidelines for Americans. So forgive me if this is redundant. Since 1980, the Dietary Guidelines for Americans, which are developed by the USDA and the Department of Health and Human Services, they have been updated every 5 years. There's currently a group of folks undergoing the next version of these recommendations that should be coming out next year. The Dietary Guidelines for Americans provide advice on what to eat and drink to meet nutrient needs, those 3 important nutrient needs, promote health, and prevent disease. Not prevent multiple sclerosis, but to prevent chronic conditions that folks with MS, the comorbidities that make living with MS more challenging. These guidelines are intended to inform healthy people, those at risk for diet-related diseases, and those living with these diseases already, which means this applies to all of us. And these guidelines are the jumping off point for all of those therapeutic diets that I mentioned before, because this is the important stuff we want to make sure we're getting. And if you have a need for a therapeutic diet, we want to find a specific way that we can modulate things in such a way that you continue to get these needs met. The underlying premise of the, there are five basic recommendations on here. It's to follow a healthy eating pattern at every stage of life, to customize and enjoy nutrient-dense foods, beverage choices, and to reflect, and here it's in the guidelines, reflect personal preferences, cultural traditions, and budgetary considerations. This means you don't have to shop at Whole Foods. You get to enjoy your grandma's Christmas cookies, and you get to do traditional foods, whatever they may be. So it's right there in the science. And to focus on meeting your nutrition needs with nutrient-dense foods, beverages, as opposed to supplements, because the human body prefers to get those nutrients from foods, and to stay within your calorie limits. The only 2 limitations are alcoholic beverages. Doesn't say to avoid them entirely, it says to limit them, as well as limiting foods and beverages that are higher in saturated fat, added sugars, and sodium. The core, I'm not going too much into food, but I want to list this, if I can, for just a moment. Follow a healthy, the foods that we're intended to include on a regular basis include vegetables of all types, fruits of all types, grains, especially whole grains, dairy, protein foods, while focusing on meeting these, the nutrient-dense foods more frequently. But there's no real food that we're supposed to necessarily avoid. I mention this because it's boring, right? It's boring. It's what Grandma used to say. It's boring. It's simple. However, it's not necessarily easy because apparently as a population, we're not doing very well at meeting these needs. This is a very busy chart, but let's see. If you look at the bars in purple, that's the percentage of the population not meeting, that is meeting the recommended intake of those foods. Everything in blue is what we're not meeting, the percentage of the population not meeting the needs. And we are indeed over-consuming some things, some refined grains, as well as protein foods, meat, poultry, and eggs. Everything else, we fall dramatically shy of meeting our nutrient needs. So contrary to clickbait, the refrain of messaging around restrict, avoid, limit, stay away from, good foods, bad foods, really we need to be focusing on telling our people to eat more, focusing on addition, right? Add the colorful plant foods, as well as the whole grains, which don't cause inflammation, by the way. And sugar is not inflammatory. Fruit is not high in sugar. I get those comments all the time about people who avoid fruit for sugar contents. But, so there are so many examples of MS diet clickbait messaging that I could go into, and you may have heard, you may be familiar with some of these, grains and legumes, starchy vegetables, fruits and eggs, which are somehow arbitrarily bad for people with MS. People out there promote food sensitivity testing, elimination diets, and then diets to somehow modulate autoimmunity, expensive supplement regimens, and vocabulary like MS-friendly or MS-unfriendly foods. But for today, I wanted to take a deeper dive into one of these topics and see how they came to recommend, or how they came to this process, and that's dairy. Apparently, Clickbait thinks that people with dairy are strongly advised to avoid dairy. And the problem with this and other recommendations is that when they offer a citation of any kind, it often links back to mice studies, epidemiological studies that are really not ready for, they're not ready for prime time. Including mice studies and/or epidemiological data that have significant limitations in their ability to directly translate human health outcomes. Relying on these types of studies alone ignores the complexity of human nutrition and the multifactorial nature of complex diseases like multiple sclerosis. And then, of course, there's the personal testimonials and anecdotes. It worked for me. Personal testimonials and anecdotal evidence, while compelling, are inherently subjective and prone to confirmation bias. They do not meet the rigorous standards of clinical research necessary to establish nutritional guidance. And clickbait recommendations are often delivered with emotionally charged language in terms that have no clinical meaning, like clean food and inflammatory food. And I'd just like to point out, there's no food that, if consumed in isolation, is inflammatory unless you're allergic to it, because inflammation is an immune response. So no such thing. Food is not MS friendly or MS unfriendly. And ultimately, it's because there is a lack of consensus. The relationship between dairy consumption and multiple sclerosis has not been studied. There's no support for a clear scientific consensus. Isolated studies may pose potential links, but the broader body of high-quality research does not consistently demonstrate a clear causal relationship. And I'd like to give you two studies. I don't want to go deeply into them. They're listed at the bottom of this slide, as well as in my citations. There are two studies that take a different approach to what they recommend in the way of dairy. First is Chunder et al., which is a mice study that used a clinical scoring system to observe any signs of weakness or disability in mice after immunization with dairy proteins, helping to assess the severity of the disease induced by delivery of casein protein, which is a milk protein. And it turns out that injecting dairy proteins like casein into mice shows the effects like spinal cord pathology, which is a way to study the disease. The results of this study have actually been used to create that headline that people with MS are strongly encouraged to avoid dairy products. Another study, the data from a metagenomic study conducted by Tian et al., comprised of 517 Chinese peri- or postmenopausal women, supports the biological value of habitual cow milk consumption, potentially influencing the gut microbiome's composition and function in ways that could be beneficial for health, particularly in the context of menopause. So, do the results of the metagenomic study apply to non-perimenopausal or menopausal women? How about men? Do the results of the mice study apply to humans? I will point this out, that when humans consume milk, we do it orally, which digestion changes those proteins before they enter our body's system. And that context changes our understanding of how humans tolerate dairy products as opposed to injecting the proteins into our veins. But our patients don't necessarily understand that. So if they're clicking through to that resource, they're not going to be able to make that distinction. That's up to us to be able to explain that to them. Anyway, the answer to the question is that, the answer to the questions about does this apply, and this is the problem with taking these isolated studies. One study says habitual cow milk consumption is a bad thing or a good thing. So really, we need to be relying on the comprehensive evidence and the consensus. And so because I mentioned consensus, I've listed for you on this slide what is the consensus according to the dietary guidelines for Americans on the consumption of dairy. Dairy products are recognized as an important source of key nutrients like calcium, potassium, vitamin D, and protein. They support bone health, muscle function, and overall health. Bone health is really important for folks with MS as we're at an increased risk of fracture. The DGA recommends consuming dairy products as a part of a healthy eating pattern. This includes milk, yogurt, cheese, and then if for any reason you abstain from dairy, to make sure your alternative is fortified with those important nutrients. And the dietary guidelines encourage choosing low-fat or fat-free dairy products to reduce the saturated fat content that we get from our diet, because those things are associated with cardiovascular disease. And again, they recognize that for whatever reason, if you choose to abstain from dairy, make sure your alternative is fortified. So this brings us to the communication gap, right? I've mentioned, there's no big, a lot of questions out there. There's no clear consensus on what it means to eat well, specifically to somehow or other impact the MS disease process. But it's important to remember when you're getting questions to try to be mindful of not providing overly simplistic, don't use overly simplistic language. We want to empower people to make better food choices, but try to refrain from using language that says, doing this will help you retake control over your disease, because that's a promise that you can't keep. So I find that I find a lot of people who come to me are on the other side of having heard that advice, and it can be very devastating when it turns out they still have MS and it still progresses, even though they avoid milk. And remember to reflect on personal biases, because we all have them. When you're outside your comfort zone, dietitians are there. Even if they're not in your clinic, it's really a good idea to remember you can refer to them. And I mentioned here the scope of your practice, because my scope of practice entitles me to discuss exercise, drug-nutrient interactions, and emotional well-being as it relates to food. So I can do that, but there's a limit. I can encourage somebody to exercise based on the federal guidelines. I'm not going to design a physical therapy regimen for somebody with pelvic problems. I'm just not going to do that. That's where I'm outside of my comfort zone and I'm beyond the scope of my scope. So I'm going to refer my patient to a physical therapist or the appropriate professional. Remember your patient's expectations. It's not so much what you say as it is what they hear. That's why I encourage you to refrain from language that might encourage them to think that they're going to heal, beat, reverse, cure, or control their disease. Be mindful that whatever you're recommending may have an impact on physical, mental comorbidities. And then finally, it's really important to remember that diets are not risk-free interventions. Meeting nutrient needs is far more important than whatever the title of your eating pattern. And I say this because the Mediterranean diet is something that everyone recommends, and that's fantastic, but it's not even a standardized diet. It's just a regional eating pattern. And it also happens to align almost precisely with the dietary guidelines for Americans, which brings me to the dietary guidelines for Americans have provided you resources that, regardless of your scope of practice, these things are wonderful tools for you to share with your patients. The picture on the left, the blue, is the ubiquitous MyPlate image, which depicts how to build a healthy plate. And then in the center image, like the Mediterranean diet, when people think, oh, Mediterranean diet, I need to go buy a cookbook because I don't know what that is. This center image, which is available at the myplate.gov website, it provides a checklist. So if your patients are overwhelmed with the multi-syllabic Mediterranean diet, this is a checklist based on the calorie needs. Eat this many servings of vegetables, and it breaks it down for you. And that is available as a printout at myplate.gov. It's also an app here on the right, Start Simple with MyPlate, which provides also grocery lists and gamification. They get badges when they complete their goals. And I'm going to keep this, for the sake of time, very brief, but when it becomes a need for a more therapeutic conversation around nutrition, I encourage the use of the Determine checklist. Has anyone heard of this or familiar with this? No. Okay. You can access it. The citation is on my slide. Basically, it is a nutrition screening tool that was developed by the Nutrition Screening Initiative, a collaboration between the Academy of Family Physicians and the American Dietetic Association, now the Academy of Nutrition and Dietetics. And it was initially thought, people wanted to use it as a nutrition screening tool. Long story short, it was less than sensitive for some things. So certain studies, follow-up studies, have found that it would be best used as an education tool. I like to think of it as a conversation guide, because whereas most of your facilities have a malnutrition risk screen in there, it only uses BMI and/or weight loss. The questions that are provided in this tool address a number of 9 different categories of situations that could put our folks at nutrition risk. And nutrition risk is different than malnutrition. We mentioned that our population is getting older. Our multiple sclerosis population is getting older. Another thing that comes along with age is malnutrition. And if we as MS providers are not looking at nutrition status prior to old age, then we've already got malnutrition. Whereas if we identify these problems in advance, we can potentially intervene. I won't go through all of these questions, but if you would like, I've created for interns I work with a follow-up rationale conversation to help guide a conversation with patients on this. It's easy to score, and it lets you know if you are at risk. And if you are at risk, then it's not necessarily for you, the physical therapist, the nurse, whoever, to come up with the answer to that right on the spot. It may be very informative for how you should refer the patient to help get that intervention met. And then before I go, I want to say that as our new but mighty dietitian special interest group, we have a survey that we are using to better understand the perceptions and utilization of registered dietitians in the MS care community among members of the multiple disciplinary team. If you wouldn't mind taking time to take that survey, we would all really appreciate that. And my citations are there. And again, I'm happy to answer any questions that you may have. I'm going to put it back up there, so in case anybody wants to do that. No questions?
That was some excellent resources.
Well, thank you.
I have learned so many things today from this lecture, and I think that this just shows that we all have probably been lacking yet another person for our multidisciplinary team. And, I think the theme that we have heard throughout the consortium is that we are having aging of our MS patients. And you think about social isolation, folks that are not able to get out, and this is just an excellent team member that can work with that patient to look at what can they do within their own home. And also, I think this has just been a wonderful addition. Well, I do want to thank all of y'all that have hung around with us. Thank you so much. I want to thank the faculty. They're just excellent speakers and topics today. We do have our closing ceremonies tonight, even though if you're still staying till tomorrow, we have many sessions tomorrow. So they are going to start at 6 o'clock. It goes from 6 to 7:30. It's the closing ceremony and the award ceremony. They'll have food and drink there, and it is up on the 4th floor, the Carl Dean Ballroom. Now, we do have session 4 tomorrow that will finish up our fundamentals of MS care that starts here in the morning at 9:15. So if you're available and still want to hang around, please come with us tomorrow. So thank you all for your attendance today. Do the evaluations. I always forget to say that. Please give us positive, give us negative feedback so that we can make our plans for next year. Thank you.